What is cirrhosis of the liver? Cirrhosis is a condition which your liver is scarred and permanently damaged. Scar tissue replaces healthy liver tissue and prevents your liver from working normally. As your cirrhosis gets worse, your liver begins to fail. If you are new, please like, share, subscribe and click the notification bell for updates of my new video.
A healthy liver contains very little or no fat. If you drink too much alcohol, or eat too much food, your body deals with this excess by turning some of the calories into fat. This fat is then stored in liver cells. The fat in liver cells can build up. If there is too much, you have fatty liver. Liver fibrosis is the excessive accumulation of extracellular matrix proteins, including collagen, that occurs in most types of chronic liver diseases. Advanced liver fibrosis results in cirrhosis, liver failure, and portal hypertension and often requires liver transplantation.
Fatty liver: a buildup of fats in the liver that can damage the organ and lead to serious complications. Risk factors include obesity, a high-fat diet, high alcohol intake and diabetes mellitus. Fibrosis alters normal liver structure and vasculature, impairing blood and lymph flow and resulting in hepatic insufficiency and hypertension in the portal vein. Complications include hyponatremia, water retention, bleeding, esophageal varices, coagulopathy, spontaneous bacterial peritonitis, and hepatic encephalopathy. Cirrhosis is scarring of the liver caused by continuous, long-term liver damage. Scar tissue replaces healthy tissue in the liver and prevents the liver from working properly. The damage caused by cirrhosis can't be reversed and can eventually become so extensive that your liver stops functioning. 3 major forms of liver cirrhosis. Leydig cirrhosis. This is the most common form of cirrhosis and results from chronic alcoholism and malnutrition. Post-necrotic cirrhosis. Consists of broad bands of scar tissue and results from previous acute viral hepatitis or drug-induced massive hepatic necrosis. Biliary cirrhosis. Consists of scarring of bile ducts and lobes of the liver and results from chronic biliary obstruction and infection, cholangitis, and is much rarer than the preceding forms.
Causes and risk factors: viral infection, obesity, genetic abnormalities, alcoholism, high-fat foods, illicit drugs.
Signs and symptoms: sparse body hair, dilated vessels, spider angioma, ascites, encephalopathy, jaundice, muscle wasting, red palm.
Signs and symptoms: compensated cirrhosis, usually found secondary to routine physical examination, vague symptoms.
Decompensated cirrhosis. Symptoms of decreased proteins, clotting factors, and other substances and manifestations of portal hypertension. Liver enlargement early in the course, fatty liver; later in course, liver size decreases from scar tissue. Portal obstruction and ascites. Organs become the seat of chronic passive congestion, indigestion and altered bowel function result. Infection and peritonitis. Clinical signs may be absent, necessitating paracentesis for diagnosis. Gastrointestinal varices, prominent, distended abdominal blood vessels, distended blood vessels throughout the GI tract, varices or hemorrhoids, hemorrhage from the stomach. Edema. Vitamin deficiency, A, C, and K, and anemia. Mental deterioration with impending hepatic encephalopathy and hepatic coma. Assessment and diagnostic methods. Liver function tests, example, serum alkaline phosphatase, aspartate aminotransferase AST, serum glutamic oxaloacetic transaminase, SGOT, alanine aminotransferase ALT, serum glutamic pyruvic transaminase, SGPT, GGT, serum cholinesterase, and bilirubin, prothrombin time, ABGs, biopsy, ultrasound scanning, CT scan, MRI, radioisotopic liver scans. Medical management. Medical management is based on presenting symptoms. Treatment includes antacids, vitamins and nutritional supplements, balanced diet, potassium-sparing diuretics. For ascites, avoidance of alcohol. Colchicine may increase the length of survival in patients with mild to moderate cirrhosis. Nursing management. Promoting rest. Position bed for maximal respiratory efficiency, provide oxygen if needed. Initiate efforts to prevent respiratory, circulatory, and vascular disturbances. Encourage patient to increase activity gradually and plan rest with activity and mild exercise. Improving nutritional status. Provide a nutritious, high-protein diet supplemented by B-complex vitamins and others, including A, C, and K. Encourage patient to eat. Provide small, frequent meals, consider patient preferences, and provide protein supplements, if indicated. Provide nutrients by feeding tube or total parenteral nutrition if needed. Provide patients who have fatty stools, stearia, with water-soluble forms of fat-soluble vitamins A, D, and E, and give folic acid and iron to prevent anemia. Provide a low-protein diet temporarily if patient shows signs of impending or advancing coma. Restrict sodium if needed. Providing skincare. Change patient's position frequently. Avoid using irritating soaps and adhesive tape. Provide lotion to soothe irritated skin. Take measures to prevent patient from scratching the skin. Reducing risk of injury. Use padded side rails if patient becomes agitated or restless. Orient to time, place, and procedures to minimize agitation. Instruct patient to ask for assistance to get out of bed. Carefully evaluate any injury because of the possibility of internal bleeding. Provide safety measures to prevent injury or cuts, electric razor, soft toothbrush. Apply pressure to venipuncture sites to minimize bleeding.
Monitoring and managing complications. Monitor for bleeding and hemorrhage.
Monitor the patient's mental status closely and report changes so that treatment of encephalopathy can be initiated promptly. Carefully monitor serum electrolyte levels and correct if abnormal.
Administer oxygen if oxygen desaturation occurs. Monitor for fever or abdominal pain, which may signal the onset of bacterial peritonitis or other infection. Assess cardiovascular and respiratory status. Administer diuretics, implement fluid restrictions, and enhance patient positioning, if needed. Monitor intake and output, daily weight changes, changes in abdominal girth, and edema formation. Monitor for nocturia, and later, for oliguria, because these states indicate increasing severity of liver dysfunction.
Promoting home and community-based care. Prepare for discharge by providing dietary instruction, including exclusion of alcohol. Refer to Alcoholics Anonymous, psychiatric care, counseling, or spiritual advisor if indicated. Continue sodium restriction. Stress avoidance of raw shellfish. Provide written instructions, teaching, support, and reinforcement to patient and family. Encourage rest and probably a change in lifestyle, adequate, well-balanced diet and elimination of alcohol. Instruct family about symptoms of impending encephalopathy and possibility of bleeding tendencies and infection.